Assalamu alaikum colleagues. Welcome back. In last video, we dealt with the thyroid. Now we are moving towards the adrenal gland. We are also starting this video with a nightmare scenario. Let's suppose a 10-day-old male infant present to you in emergency room. The age of the infant is 10 day and he presents as gray, mottled and lethargic. The parent tells you he has been vomiting for 24 hours. The child is vomiting for 24 hours. You look at him and you think sepsis. You start antibiotics, you start fluid, and you send labs. But then the lab returns and you are surprised with the lab results. The potassium of the child is 8.5 and the sodium is 125. So, if you keep treating for sepsis and miss the adrenal crisis, this baby will definitely die from a fatal arrhythmia or refractory shock. Congenital adrenal hyperplasia is a gender disease. In females, the anatomy often shouts the diagnosis on day 1. So, usually the females have genital ambiguity. But in males, the anatomy is normal. So, male child usually goes home and only return in salt wasting crisis 2 weeks later. So, if you receive any neonate in second week of life, which is male and presented with vomiting for 24 hours or more, and you suspect the child is having salt crisis, you should send their electrolytes and start treating them as well. Suspect CAH. In this lecture, we will master the 21 hydroxylase deficiency, the 17 hydroxyprogesterone screen, and the acute stress dosing protocol that you need to save the life. So, 21 OH deficiency, 17 hydroxyprogesterone screening, and the acute stress dosing protocol. Starting with the absolute basics of biochemistry. According to Nelson textbook of Pediatrics, 95% of congenital adrenal hyperplasia cases are caused by 21 hydroxylase deficiency. If you have a basic knowledge of adrenal cortex is a factory line for making three essential products. So, adrenal cortex is a factory for making aldosterone, which is the salt keeper, the cortisol, which control the sugar and stress, and the androgens, which are the sex hormones. In classic congenital adrenal hyperplasia, 21 hydroxylase is missing or non-functional. So this factory cannot produce cortisol. The deficiency of 21 hydroxylase leads to decrease or absent production of cortisol, which leads to hypoglycemia and shock. Second one is the non-production of aldosterone. So aldosterone is basically for salt retention. So, decreased production or minimal or not any production of aldosterone resulting in salt wasting. Because the precursor pathway is blocked, all the raw materials which are used to produce these hormones will pile up and spill over into the only open lane, that is the androgen pathway. So here 21 hydroxylase deficiency is decreasing the production of cortisol and aldosterone, but on the other way it increases the production of androgen because the precursors which are producing this is going towards the androgen pathway and increases its production. So here is androgen excess, which results in virilization in females. So we catch this disease by screening for the precursor that piles up behind the block. That is the 17 hydroxyprogesterone. So we screen every baby neonate for 17 hydroxyprogesterone. But be careful with premature infants. In premature infants, 17 hydroxyprogesterone is naturally elevated and it is also elevated in sick babies, leading to frequent false positives. So, we usually screen for it, but there are few false positives as well, such as in preterms and in sick neonates. So, as per the 2025 approach, if you get a positive screen in a asymptomatic or preterm neonate, do not panic. Repeat the test and check electrolytes. So 2025 updates emphasizes that if we get a positive result in preterm or asymptomatic, we should repeat test as well as we should order the electrolytes. And in the symptomatic, if the baby looks sick or has ambiguous genitalia, draw confirmatory labs. If the baby is symptomatic or having ambiguous genitalia, we should go for confirmatory labs. 17 hydroxyprogesterone, electrolytes, cortisol, and renin. I have started this lecture with a case scenario of a male neonate. But there is another scenario, that is the virilized female. These infants are often identified at birth. The excess androgens in utero causes masculinization of the external genitalia. So in females, androgen is increased in utero, so it results in few signs which helps in identifying this child to have CAH. You might seen that signs in few of your neonate, female neonate, that is clitoromegaly, which can resemble a small phallus, and the fusion of labioscrotal folds, resembling a scrotum. So female neonate having CAH usually identified at day 1 because of excess androgen resulting in clitoromegaly and labioscrotal fold fusion. Here you have to be very vigilant. The key is the gonads. If you see a baby with undescended testes bilaterally, stop. Gomila states clearly, any infant with bilateral cryptorchidism should be suspected of having virilizing adrenal hyperplasia until proven otherwise. So you should check for gonads if you are dealing with any child with ambiguous genitalia, and if the gonads are undescended bilaterally, you should check for karyotyping and 17 hydroxyprogesterone immediately to confirm the gender of the baby. This is the case scenario for virilized females. In males, males usually appear with normal genitalia and there are no external clues. These babies typically do well for the first few days, but as maternal hormones wear off and the salt wasting progresses, they present between the day 7 and day 14 of life, as discussed in this case scenario. They present with severe weight loss, dehydration, and projectile vomiting. So we should have both case scenario over here. Male usually present with vomiting and dehydration, while females usually identified at day 1 due to their ambiguous genitalia. We should look for metabolic pattern to identify salt wasting crisis. So you should have a basic knowledge of metabolic pattern, which we have dealt over here. That is the hyponatremia. Usually sodium is less than 130 milliequivalent per liter. Hyperkalemia, usually greater than 6 or even greater than 8. Hypoglycemia due to cortisol deficiency and metabolic acidosis. Now you have identified the baby having salt wasting crisis. You have to manage this acute condition immediately. So forget the genetics for a moment. You have to act immediately because the baby is in shock. You have to give fluid, that is in the form of boluses. Normal saline boluses usually give at 20 ml per kg to restore the perfusion. And if the baby is hypoglycemic, we usually give 2 ml per kg of 10% dextrose. After the fluid, we should replace the missing cortisol immediately to support vascular tone. So you have to replace the hormones. First one is cortisol, and for the cortisol we give hydrocortisone. This is the drug of choice because it has both glucocorticoid and mineralocorticoid activity. Acute dose for hydrocortisone is approx 50 to 100 mg per meter square, or a stat dose of 25 mg IV for a neonate. Once the child is stable, we move to maintenance dose, and the maintenance dose is usually 10 to 15 mg per meter square per day divided 8 hourly. After the hydrocortisone, we have a another hormone which is fludrocortisone. This is your pure mineralocorticoid that is for aldosterone replacement, and it is used as oral only. So you have to wait till the baby stabilizes or can tolerate oral medications. We have managed the shock condition, we have managed the hormone deficiency. We have to manage for hyperkalemia as well. For hyperkalemia, first line is fluid resuscitation along with hydrocortisone, usually often simply restoring renal perfusion and providing mineralocorticoid effects will wash out the excess potassium. But you have to look for ECG changes. If you see a peak T wave or a widened QRS complex, you should have to protect the heart with calcium gluconate. So, if there is peak T wave or widened QRS, you should give calcium gluconate to protect the heart. Calcium gluconate stabilizes the heart membrane. This is for the acute management. But you should counsel the parents for maintenance and sick days. So here is a maintenance therapy as well. The goal is to replace what is missing and suppress the ACTH drive that causes androgen spillover. So usually in maintenance, we give oral hydrocortisone 10 to 15 mg per meter square per day. We give oral fludrocortisone 0.05 to zero point 0.2 mg per day to maintain sodium balance and normal renin levels. But as the breast milk is low in sodium, neonates often require oral sodium chloride solution supplements. So for neonates or those having only on breast milk require NaCl solution approx 1 to 2 gram per day divided in between the feeds. This is for the treatment, maintenance treatment. You should have to teach the parent for the sick day rules. If the baby is under stress, that is having fever, having any vomiting episodes, surgery or trauma, you should counsel the parent to triple the dose of hydrocortisone. That is, you are giving 10 to 15 mg per meter square per day. So counsel the parent to triple this dose. So during the stress, we have to triple the maintenance dose. And in emergency, if the child is vomiting and cannot keep the oral meds, the parent must inject hydrocortisone IM immediately and proceed to the ER. This is non-negotiable. So, if the child is not taking anything orally, you should also counsel the parents for hydrocortisone IM injection and have to tell to proceed to ER or rush to the ER. This is all about today's lecture. But adrenal crisis is a master of disguise. It looks like sepsis, it looks like pyloric stenosis. But if you see that combination, that is low sodium, high potassium, low sodium, high potassium, stop and think for adrenal crisis. Check the genitalia carefully. If they are ambiguous, think congenital adrenal hyperplasia. If they are male and the baby is shocked, think CAH. Give saline, give hydrocortisone. This lecture is prepared after doing research with many textbooks just like Gomela's, Nelson textbook of Pediatrics, Neonatal guidelines, and this is purely for educational purpose. This is not intended for any consultation or any medical treatment. If you have find this condition in your baby, consult your doctor first and took advice from him or her. This is all about today's video. Inshallah, in the next video, I will discuss another topic related to neonatology. Till then, Allah Hafiz.